Welcome to another episode of the Individuation podcast. I'm Dr. Lahab Al Samurai, and today I have a special guest. Jamie Kreider is here. She is a licensed clinical social worker, and she has a secondary designation as a prenatal
Perinatal mental health certified.
perinatal mental health certified. She'll
Yep.
tell us more about that and hopefully tell us about herself and her practice and what she does and how she does it. It would be um, very enlightening to all our listeners. And tell us, where are you located right now?
I am coming to you from Chicago.
Chicago. Okay, great. So that's my old hometown. I love Chicago. Where are you in Chicago?
We are in Logan Square. We're in the city.
Oh, love Logan Square.
Mhm.
We used to live right on the corner of Byron and Hoyne.
Oh,
Uh,
sure.
yes, in Irving Park. Irving Park was there was a diner under the L stop that I used to have breakfast at. There's an old couple who used to own it. Their food wasn't great, but the atmosphere was fantastic. They were so kind, so I always ended up being there. So, why don't you introduce yourself to our listeners,
Great.
Jamie? Yeah.
I'd love to. And Dr. Lahab, thank you so much for having me on the podcast. I'm really honored to be here. So as mentioned, my name is Jamie Kreider. I'm a licensed clinical social worker and a perinatal mental health certified clinician, which is a newer designation. I was licensed, one of the first few cohorts licensed back in October 2018. Um, it's sponsored by Postpartum Support International, which is great to have clinicians who do what I do sort of practicing under one umbrella.
Oh, fantastic.
Yeah.
So, what is it exactly that uh, you do?
So I'm a therapist,
Mm-hmm.
and I am the founder of Nurture Therapy, which
Mm.
is a counseling practice here in the Chicagoland area. We have two locations, and we're on virtual therapy right now. And we specialize in maternal mental health and the treatment of perinatal mood and anxiety disorders.
Ooh,
Yeah.
interesting. Okay, so
So
you work with mothers who have had babies, and
so
both
we
parents or just one parent?
So we actually work with individuals and couples throughout the reproductive journey.
Ooh.
Perinatal mood and anxiety disorders is the umbrella term that we use to understand any kind of mental health stressor or disorder that's occurring during pregnancy
Mhm.
or in the postpartum period, which is 1 year following delivery. In our practice, we understand that reproductive health expands much more than that. So we also work with individuals who might be going through fertility challenges. We work with individuals and couples who might have experienced a pregnancy loss.
Mm.
We
How
work,
do you work with such a couple? What would be some of the things that you would talk to them about or work with them on?
couples who are experiencing fertility challenges or
Yeah, yeah, those who have had loss or fertility challenges, uh, what type of therapy do you do with them? Can you
So we
tell
do
us about that?
evidence-based approaches, but I also think just being there for individuals who have experienced these kinds of losses or these kinds of challenges. Um, Pregnancy loss and really everything that we're going to talk about today. Um, it's real, it's challenging, it's not given enough attention. And so it's nice to create space for our individuals and our couples and our families who are going through any kind of stressor when it comes to pregnancy and parenting.
Yeah, I think what you do is amazing because I have several patients who did not have the treatment during those times when they were pregnant or that postpartum depression was never treated, never diagnosed, they weren't taken care of, and have carried depression and anxiety for many, many years. So I really appreciate that you're working with this population, because I think this population requires a lot of attention. We don't give our expecting mothers and dads support in society anymore.
Right, right. Um, and this is really common. So statistically, the number varies, but 1 in 7 or 1 in 5 women will experience depression or anxiety during pregnancy or in the postpartum period.
Mm.
And this statistic is unfortunately greater for women of color. About 40% of women of color
Yes.
will experience depression after delivery. So it's so important. I appreciate that you recognize it. And it's so often untreated.
Correct. Yeah, I agree with you. I think I think it's missed because I think it's misunderstood as something that occurs during childbirth, which
Mm-hmm.
has nothing to do with that. This
Right.
is a different emotional, psychological condition that occurs.
And I think that we live in a society and a culture that focuses on baby, right? So, for example,
Not in a good way.
I mean, in an important way also, but we're missing a huge piece of that dyad, right? We're missing mother or the birthing person. And so I think it's sort of important to think about too.
We look at baby, we look at baby as image more than we look at baby as being. And I think that's what, kind of is strange.
Mm-hmm.
We don't look at like young families that might struggle or might have issues because they've never done it before. They've never raised a child before. They've never had a baby before, And so people show pictures of babies, but usually, just images. It's not what is happening with these young couples and how they're taking care of, this child. And because it's a lot of stress for young couples, right?
Sure. I think it's, especially after someone gives birth, they're healing hormonally,
Ooh,
emotionally,
ooh.
physically, right? You're exhausted.
Explain the hormonal, the physical. If you could give just like some brief, just so our listeners can get an understanding of what you're talking about.
Sure, I'm happy to. So, obviously, an individual who's pregnant, their body changes a lot and goes through a lot of hormonal changes. After delivery, those hormones are going back to their pre-pregnancy state, and this is happening pretty rapidly. We understand this as a mental health condition. It's called the baby blues.
Mm.
And baby blues represents that hormonal adjustment.
Mm.
Usually what that looks like is, a birthing person will feel overwhelmed, exhausted, perhaps cry a bit more than usual. We come to expect that in the postpartum period. But this is a phenomenon called baby blues. It usually occurs about 1 to 3 days after delivery and lasts 2 weeks. Anything after 2 weeks, we're looking at something else. We're looking at either kind of a mood or anxiety disorder that's occurring.
Why 2 weeks, Jamie?
So 2 weeks is what has been identified as that hormonal change. So baby blues is not something we diagnose. Baby blues occurs in 80% of women, so it's more common than not.
So this is the body resetting back to homeostasis,
exactly,
right?
Exactly. And there's a word that we use to describe mothers and motherhood. It's called maturescence. And similar to adolescence, right? We expect adolescence is a great time of change, hormonal changes too. There's this idea that mothers are also born, that there's this huge shift, again, hormonally, emotionally, physically that happens, and mothers are also born just like babies are. But so that's what I mean by, all of these changes are happening all at once, and you're also in charge and responsible for this new little baby that's come into your life. And here in the US, we don't do this as well as other cultures do. Other cultures have these rituals and traditions surrounding moms. When they come home, they live with parents or in-laws, or the community gathers around to kind of take care of mothers in a way that's just not here.
Yeah, which helps the young mother who is also physically recovering from giving birth time and emotional support to reconnect and kind of draw back her ability to connect with baby, which is required really early on, because we know what happens when mother and baby are not getting along very early on. It can be very problematic. You
Right.
want to talk about that a little bit?
Yeah, I can talk about early attachment relationships.
Mm.
So attachment is so important, and that happens between baby and caregiver. And what we see with mothers who are really depressed is they're not available for babies in the way that babies need. Right? So, we kind of need to think about maternal mental health as, first of all, a mental health crisis, right? A national crisis that needs to get more attention, but also that can affect multiple generations. This impacts mom and partner and baby and community. It really impacts everyone. And there's some, we see some social, emotional, and cognitive long-term effects when babies are with mothers with untreated depression. The good news is this is really treatable. Everything we're going to talk about today is really, really treatable.
Okay. Okay, great. So we're thinking of the mother and child and the father or the other mother or the other father, or depending on who the parents of this child are, and does not matter for gender. But in terms of the mother and the child, in terms of that relationship, how is it for the mother when she awakens to the idea of the newborn? What is it like? What is that experience like? I think our male listeners might actually learn something.
I hope all your listeners learn something. I think that relationship is different for every mother. A mother who's struggling in the postpartum period, what that can look like is that she feels depressed and she has this new baby. I should also say that there's all these myths about pregnancy and motherhood. And one of the myths that we hold is that you're going to be immediately bonded with your baby, and that it's going to be this love at first sight, and that you're going to be kind of good at mothering right away. And so I think we tell ourselves this, and mothers who are struggling in the postpartum period, they feel like, they're not experiencing joy from their new baby. Then they're feeling guilty because they're not experiencing this joy. Maybe they're depressed. Maybe they're really anxious. Maybe they're having intrusive thoughts. Maybe they're having suicidal thoughts. And they're feeling like a terrible mother. And often we hear this passive suicidal kind of self-talk that says, my family would be better without me. The baby would be better without me. That's really painful to experience at any point of motherhood, but particularly early motherhood.
It's traumatic.
Yeah.
It's
absolutely.
traumatic to the relationship. Baby, it's traumatic to the idea of motherhood. It's like an early sledgehammer blow for motherhood.
It is. At Nurture Therapy, our philosophy is that we need mothers to be healthy for the family and the baby to be healthy. And so our treatment starts with the mother, right? The birthing person. So that's really who we focus our therapy on.
So how does your process work? How is it the weekly? Is it the monthly? How do
So
people see you? What type of consultations are there? I don't know.
sure. So we provide mostly weekly therapy as
Mm,
a, an individual or
mm,
couple progresses. It might go down to every other week or monthly.
mm,
Um, we start with weekly. Here's the kind of kicker about what I do is we focus on this population, this perinatal population.
mm,
It's really hard to get a new mother to come into therapy, right?
mm,
What new mother has time to come into therapy? Uh, so, they're exhausted. They're not sleeping. They have this new baby to take care of. They're not feeling like themselves, right? They're feeling depressed. They're feeling anxious. They're feeling kind of a range of things. And then someone says, you have to go to therapy.
mm,
So we try as best we can to break down those barriers. So one of the things I tell moms early on when they contact the practice is our goal is your goal. We want you to feel like yourself and as quickly as possible. So sometimes the treatment isn't long-term treatment. Sometimes it is. It ends up being a nice space for mothers and individuals to come and have, an hour session for themselves, as therapy tends to be, as I'm sure you know.
mhm,
Um, so, but we do say that. We say our goal is your goal. We're working on kind of the immediate stressors. We're using evidence-based practices to help you feel better, feel like yourself, and as quickly as possible. Now, some of my clients have been with me for years now. We've
mm.
gone through first pregnancies and subsequent pregnancies, and it has become obviously something else. But when I'm working with mothers, that's what I'm thinking about. This mother wants to feel better and she wants to feel better fast.
So is your practice now on Zoom or is it in?
So I actually started my practice in New York City
Mm,
in 2016.
mm,
And then Chicago is home. We relocated back to Chicago and relaunched my practice here. So I've always had a large virtual aspect of the practice.
okay.
And it's great with a new mom who's maybe on
Mm,
maternity leave, who the thought of going to an office feels like a major barrier.
smart.
Yeah, so that's been great. So
Mhm,
we did some adjusting, but we were able to get running quickly.
mm. Well, tell me about yourself, Jamie. Tell me about what makes you tick. Why you do this stuff?
So I'm a mother myself, but I've
Okay.
been doing this work for much longer than I've been a mom. Uh, I've always been interested in this work, and I didn't necessarily have the name of perinatal mood and anxiety
Mm,
disorders because again, it doesn't get the attention that I think it really needs, or how prevalent
mm,
this mental health concern is. So my first job out of graduate school, I was working with pregnant and parenting young mothers
mm,
who had a mental health condition and they were living in a transitional living program.
mhm,
Um, and now I know this is absolutely a recipe for and a risk for a perinatal mood and anxiety disorder. Um, and we weren't treating these young women like for this.
mm.
We were working on basic skills and working with
How to
them
boil
for
water, how to make milk for child. Yeah, I know
sure,
that.
sure. And we were working with them as they were aging out of this living program. So it was about independence and self-sufficiency and all of these things that is really difficult when you have a young child.
Throwing them out to the wolves, I think we call
It was a really difficult position.
it. No, 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 I know. I know the system. I know how it works. Yeah.
Yeah,
Throwing them
yeah,
out into the wolves. It's not us, it's the system. The system is is predicated on that. At a certain point, you're 21, you're out of the system.
right,
Huge
absolutely.
problem for
So,
kids because they've been in the system all their life.
mhm. So I'm sure you can guess the program had a lot of flaws. Like the
Oh,
intention was great, but it didn't work in practice.
yeah.
Um, and I continued with my career and had other jobs in therapy. And then I worked at a hospital in an inpatient OB unit.
Mm.
and had some really wonderful mentors who introduced me to this wonderful world of maternal mental health. And this is my personality. I learned absolutely everything I could and did every training that was available. And this, wonderful practice was born from that.
Mm. Excellent.
Yeah.
Mm. So how is the situation in Chicago?
Tell me more what you mean.
Well, we are in COVID land, or this podcast, we like to call it, our regular segments have been Corona and conflict.
Yeah.
So, what is it like in Chicago right now for you? We're up in Seattle, so
Yeah.
we're kind of it's a little different for us. I'd be interested to hear about how it's going there for all of you.
Um, we've had a lot of COVID cases. It's been hard in Chicago.
Mm,
We, uh, we're a hotspot city, so there's been a lot of new cases every day. I think we had 2,000 yesterday, maybe.
mm,
Um,
that's a lot.
and this has been really hard for, as you can imagine, women who are planning to go to a hospital to deliver a baby,
Mm,
or even going uh, to prenatal appointments
mm,
because they go alone, they can't go with a partner. The experience is totally different,
mm.
uh, and
It must
makes
be a very scary time for people.
it is a very scary time. We've seen more anxiety.
Mm,
We've seen, I imagine that this will definitely increase someone's risk factor for being depressed or anxious,
mm,
during or after pregnancy.
mm,
Uh, Everything that you probably expected when you get pregnant and plan to have a baby and deliver is different.
mm,
Even one's postpartum plan, not having maybe, let's say, grandparents come to be available to help. So it's really hard. It's, we're all in this together and we're figuring it out. And it's
mm,
definitely been interesting to be a therapist during this time.
mm. There's a heightened anxiety because of fear of uncertainty and of what can happen that is not controllable. And it's kind of a fantasy because nothing is really controllable, but somehow people have put in their heads that things were controllable before.
Right. And that's anxiety, right?
Mm,
When we don't have control, we feel anxious. And I'm with you, we never have control, but
mm,
it's it's very scary. And we think about motherhood,
mm,
talk about not having control. Babies, while very cute, are unpredictable. So you come home to this new unpredictable little boss,
mm,
and you lose autonomy and control all at the same time.
mm. So I like how you call the little baby boss. Okay, tell me about little boss. Tell me about how little boss requires time and effort and energy. Tell me
Yeah,
about how little boss starts running your life.
it's true, right? That's exactly what happens. Um, well, I think that in part of my work is we do a lot of evidence-based interventions. So we do a lot of CBT in my practice.
Mm,
But also what we're doing is just concrete skills for new parents.
mm,
So for example, baby's up all night, mom isn't sleeping. What can that partner do to help mom? Because if you're
mm,
not sleeping, you're not functioning, and we know you're more likely to get depressed or anxious, and
mm,
not sleeping can impact things like, you know, um, your physical health, your body's ability to produce breast milk, right? All these things can be impacted by not sleeping.
mm,
And I say all this, and newborn babies do not sleep. They're up every few hours.
mm,
And so it feels really, really hard for new parents,
mm,
first time parents,
mm,
especially. And when I say that baby is the boss, because a baby needs their needs to be met.
mm,
There's no telling a baby who's screaming to hold on or to go back to sleep.
mm,
And so it does feel like you have this unpredictable boss. And it's really hard as you're adjusting.
Mm. So, what else would you like to tell us, Jamie? Tell us about, what things you're interested in, what type of things you think about, and your personal, private, public, whatever you want to share.
Sure, sure. So I'm grateful again to give some attention to this, public health issue,
Mm,
because again, we know that this doesn't just impact mom and baby, but it impacts the entire family
mm,
and communities,
mm,
and it deserves greater attention. Um, and even though we know it's prevalent, and even though I think it's getting some more attention, uh, it definitely doesn't get as much attention or funding as it deserves. So I said it could be a public health crisis. It's the number one complication impacting women following delivery. So it's
mm.
the number one complication of delivery. And it, again, doesn't get the attention it needs.
So the number one, and what do you think? How many is that? How much? What's the percentage of people affected? What's the percentage
So,
of women affected?
right, we say like 1 in 7 or 1 in 5
Wow,
women. So
that's
that's about
really
20%.
high.
And as I mentioned, this is
That's really high.
40, yeah. And we know that this disproportionately impacts women of color.
Mm.
So twice as much, 40% of women of
Why,
color.
why is that the case? Can you explain that a little bit?
So um, I think there's a lot of complicated reasons why that's the case, but I think that there's a inequality in the healthcare system.
Mm,
We know that women of color disproportionately experience negative perinatal outcomes,
mm,
and nearly 2 in 5 women being impacted by a mood or anxiety disorder after pregnancy, during pregnancy and after delivery is just one of those complications.
mm,
I think women of color face steeper barriers to getting appropriate care
mm.
during pregnancy and after pregnancy.
So access is limited.
I think it's access. I think it's, um, institutionalized racism.
Institutionalized racism and structural racism, yes.
Absolutely.
Mm,
Yeah. We know that women of color are more likely to die because of childbirth than
mm,
white women.
mm.
Um, we are, I think we have the highest maternal mortality rates of any industrialized country. Here in the US. And we can do something about it.
Mm. So,
Right, on that note.
mm,
But I think part of it is that you're right. We treat the baby. We don't, once the baby is born, we treat the baby. We don't treat the mother.
mm,
So, for example, women are discharged from the hospital usually 2 days after a vaginal birth, and like sometimes 3 to 4 days
insane.
after a C-section. I know, it's insane.
Insane. It's
Yeah.
like you just gotten a truck pulled out of you.
Exactly.
You're
Got a
being
truck full
discharged
of
after 2 days.
right.
It's insane.
And you're told to go home and
Yeah.
take
Take
care
care
of
of your
that
own
truck,
shit.
not
Yeah.
recover. Exactly. But babies are seen by their pediatrician,
Mm,
a day or so after leaving the hospital.
mm,
And if a mother has had a vaginal birth, her first postpartum visit to her OB is 6 weeks later.
wow.
So that's the first time that any medical professional is taking a look at mom, 6 weeks later. It's different, of course, if they've had a C-section or if there's some kind of
Yeah, if you had a patient, when would you see them after they've given birth?
So we can see patients right away,
Oh, okay,
especially with,
great.
yeah, with teletherapy. But, I mentioned the first 2 weeks are those baby blues, those hormonal changes.
Yeah.
But, someone should be seeing that mom after that 2-week period, right? Just taking a look at her. How is she doing? There's universal screenings. So
what about during the 2-week period? Wouldn't it be helpful to let the
sure,
mom know?
absolutely.
Yeah.
Let mom know that this is normal, right?
Yeah,
That
normalize what
baby blues,
the
exactly.
craziness that's happening.
Right. And again, one more distinction about what the baby blues is
Sure.
versus what I treat perinatal mood and anxiety disorders is baby blues go away on their own, right? They're, the hormonal changes that happen.
You're talking about the body adjusting again,
The
yes.
body is adjusting, exactly. And it's the overall mood is still joy, right?
Okay.
The overall mood is still happiness. Maybe you're bursting into tears during that happy mood, but the overall mood is still happiness. If it feels like anything else, if it feels like a dark cloud is, following you, if you're not happy, call, right? There's many providers like me that treat mothers, that treat individuals who are experiencing this. But
tell me about your background. Where did you go to school?
So I went to undergrad at University of Wisconsin, bachelor's, and then I went to graduate school at the University of Chicago, School of Social Service Administration. Yeah.
Okay, excellent. Okay. So, anything you would like to add tonight? What would you?
I'd love to tell you a little bit more about my practice and what we
Love
do
to
and
hear.
what we hope to do.
Please.
Yeah. So nurture therapy is a group practice. So there's a team of us, a team of therapists that all specialize in this area of maternal mental health. We're in 2 locations in Chicago. So we're in Lakeview, not too far from where you mentioned you were, and in Hyde Park as well. So we serve, 2 different parts of the city.
North side, west, south side.
Exactly. We take insurance, which was really important to me. And we also offer some sliding scale, on a case-by-case basis based on financial need. And we hope to open more locations.
Oh, nice.
Time to do that, but we want to open more locations. We really want to, one, we want to raise awareness that this happens, right? No one asks to be depressed or anxious, during pregnancy or after a baby is born. But there is, again, this happens. There's some normalization to it, and it's all very treatable. So that's a little bit about nurture therapy. We've done really well, and we're really grateful to be a part of such a great community of providers here in Chicago. We really enjoy the patients that we work with. Would it be helpful to tell you a little bit about some of the patients that come through our door, just in case?
Sure, that would be great. Yeah.
So usually I have a mom that calls me and she says, my doctor referred me to you, or she said something like, I'm just not feeling like myself. And she might mention some symptoms that are aligned with depression or anxiety, but a lot of this is feeling like confused about why she's not enjoying parenting more.
Okay.
Or feeling really guilty that she doesn't feel bonded to her child, or feeling exhausted, or feeling like she doesn't like this, and then feeling like a bad mom. So I hear that a lot on the phone. And the first thing I do is normalize, right? I like to normalize and instill hope. That's a little bit about my style. So I normalize.
It's a good therapeutic technique.
Right. Yeah. Because it's shameful, right? I think there's a stigma with all mental health conditions, but particularly around motherhood because of the way we look at mothers, what we expect from mothers.
We don't understand mothers.
Yeah, right. Right.
I mean, there's this motherhood thing, but we don't understand mothers.
Right.
We never taught what mothers have to do. We never. I mean, even in sex ed, they don't teach you what a mother has to do or what a father has to do or how
Right.
much baby needs time. And
Right. And and so much of what I learned from being a social worker in a
ooh,
OB setting in a hospital, right? Like the recovery process and everything that it takes. Um,
you had a
so
front seat.
right, right. So I know when you know a mother is calling me that she's probably had my card for a while, or she's probably been sitting on these feelings for a long time. You ask when we see people, I would love to see, you know, a mom come through my door right after delivery. I mean, that would be great. We know that treating this condition early really helps with symptoms
Mm,
and um, you know, again, I just sort of think motherhood doesn't have to feel this way.
exactly. That,
So, but usually it's been a while. Part of what perinatal mood and anxiety disorders, what we know is it usually peaks around 3 months. So 3 months after a baby's born. And again, it can be diagnosed 1 year after delivery,
mm,
um, which is a really long time to think about the postpartum period.
mm,
Um, so this mom calls me. I know that she's probably been sitting on my number for a long time. I really try and get moms in right away. And we take as many barriers out as we can. So babies are welcome in our sessions. You know, we don't want there to be any kind of childcare issues. It's always up to that individual. We invite partners in so they can understand and get educated a little bit about what's going on with mom. No, she can't snap out of it. No, she doesn't want to be feeling this way.
mm.
Um, and one of the first questions that I'm asking is also about intrusive thoughts. Intrusive thoughts is a part of postpartum anxiety and postpartum OCD. It's so common.
Mm.
And intrusive thoughts are unwanted, repetitive thoughts or images about something bad happening to baby or to the person herself.
Mm.
Uh, when I
What
ask,
causes that, Jamie?
excuse me,
What causes that? It sounds like there's the obsessive compulsive. Is that natural in everybody, or is that like in
it's a, it's definitely a sign and symptom of postpartum OCD.
okay postpartum
Uh,
OCD?
yeah,
Mm.
uh, it comes from anxiety, right?
Mm-hmm.
The brain looks for the worst case scenario,
Yeah.
um, and and you know
But what I was thinking, maybe I should clarify my question, is that um, this is most likely mothers who've had anxiety, or this could be anybody.
so a risk factor for perinatal mood and anxiety
Mm.
disorders is certainly a history of depression or anxiety
Oh,
unrelated to childbirth.
okay, got you.
So it could be mothers who have had anxiety in the
Mm.
past, or it could be mothers who have never had anxiety in the
Mm.
past.
I see.
When I do these talks with moms, I say every new mom worries.
Mm.
What's the difference between worry and anxiety?
Mm.
And for me, that's functioning. So I'll give another example. Every new mom is going to check to make sure her baby is breathing.
Mm.
Uh, you just are. I did it. Many moms do this. Now, are you checking?
Pre-programming.
Exactly. It's our maternal instinct, right?
Mm.
Are you checking to make sure that baby is breathing and then rolling over and going back to sleep yourself?
Mm.
Or are you up all night checking to make sure that baby is breathing? If you are up all night, you are not sleeping, and not sleeping is not functioning, and that's what we want to treat. So that's what I mean a little bit. There's certainly evidence-based interventions that are needed in that moment, but
Mm.
there's also concrete coping skills that are needed in that moment too. You know, that's when we need to loop in a partner. That's when we need to get that mom sleep. We need to get that mom sleep quickly. So can I answer your question about intrusive thoughts? Intrusive thoughts are really interesting. I talk about them all day.
No, no. For me, I just wanted our listeners to kind of get a better feel for what you're talking about, because a lot of our listeners are lay people. So it's always good to kind of, when we throw terms around like intrusive thoughts or this or that, I always like to ask, can you explain it? Because it's
Sure,
always
sure.
better than, because I could go on, we could talk about paranoia and intrusive thoughts and
Yeah.
sublimation and projection and splitting, but but
So
still we have to,
intrusive thoughts in this context
yeah.
would be, thoughts or images about some kind of harm happening to baby. And I think what makes them really scary is that sometimes it's, mom or a parent instigating this harm. So here's a great example of an intrusive thought would be, you're walking down the stairs with the baby and you have this thought like, I could trip and fall and drop the baby, right? And maybe you see that bad thing happening. Intrusive thoughts are really different than what we think about in psychosis. And I like to make that distinction because, the mom's aware of these thoughts. She's freaked out by these thoughts. That mom is much more likely to avoid walking down the stairs with the baby than she is to, engage in these thoughts. And so, but they are pretty disturbing, right? These thoughts, we can
For
be
sure.
disturbed by our thoughts. But, this happens to 90% of new moms is the statistic, and 81% of new dads. So this happens. So when I ask about this on the phone, and I give that statistic, and I, talk a little bit about how common it is, then the mom will be like, yes, actually that I have this thought. I haven't told anyone. It really scares me, or I feel like I'm going crazy. I didn't know what it is. And sometimes just having the language, this is a scary thought. This is an intrusive thought. This is because of anxiety, right? This happens. It's so reassuring.
Calling it out, naming it, becoming conscious of it.
Absolutely. So I like to do that. I like to do that on the very initial phone conversation. And, again, I provide a lot of hope, right? This is treatable. Everything I'm talking about is very, very treatable. I will mention that postpartum depression occurs in fathers and partners too. 1 in 10 dads will experience this. So it's, we treat mothers, right? And but it's not unique to mothers. And we want to include the partner in there too.
Very interesting. So you work with young mothers and their babies and their partners, and you also work in a couple of communities, it looks like. You have a couple of offices. So how many people are you that work with you?
How many therapists are in the office?
Yeah.
There are 7 of us right now, but
Okay.
we are always hiring and expanding. And, the more I do this work, the more I see that there's a need.
Huge need.
Yeah, absolutely.
Yeah, it's great work you're doing. Yeah.
Thank you. It feels really good.
For sure.
No, I'm very passionate about what I do. I feel very lucky to go into work every day. So it's good.
Excellent. So is there other things you'd like to talk about today in terms of psychotherapy, or you're bent on psychotherapy, or how you see therapy and how you see therapy occurring in the future? What do you have any thoughts?
It's a really interesting time to talk about therapy in the future because so many of us are virtual right now.
Correct.
So, and I think insurance companies are recognizing that, virtual therapy needs to be covered and exists. So, again, we've always had this virtual aspect to our practice, but what this has allowed us to do is, be providers in rural communities that might
Mm,
not have an expert, which is
sure,
important,
for
right?
sure.
Um, because postpartum depression looks different than depression, and it needs to be treated differently.
Mm.
Um,
And it's a national issue. It's not a local issue. It's not just Chicago.
exactly,
Yeah.
exactly. And there's certainly perinatal mental health clinicians all over the country, um, all over the world. So I'm in good company. Um, but it's interesting to have therapy in a virtual space, right? I
Mm,
think we think of therapy, so much of it is time and space and going into an office and,
mm.
waiting in a waiting room and seeing your therapist in person. So
Take a
it's
sledgehammer to all the old rules. They don't exist
exactly.
anymore.
And I think it's scary to shake things up in this way and exciting. And I think some of the barriers about actually getting into an office or finding a provider close to you, it'll change that too. So I have a front seat. I'm just kind of watching and waiting and seeing what happens. But
Yes.
having therapy be accessible, you know, quality therapy be accessible to lots of different communities is really important to me.
Yes, now that people have access to see therapists across the nation, across the world.
Absolutely.
So, I have people, clients, patients who call me from Kuwait, from
Yeah.
Dubai, from London, different parts of the world. I have people who seek service. So it's, I think it's a new frontier. I think it's an important frontier.
It'll be interesting to see what happens with licensing because, as you know, with therapists, that you can only practice in a state that you're licensed in.
Mm,
And what's come up, which is interesting, is
mm,
the patient has to be living in that state too.
mm.
Um, as I
That's
mentioned, we're going
for, that's for insurance.
to for malpractice.
For insurance.
So it's not insurance because if your insurance plan is in Illinois and I, visit you in Seattle and break my arm, right? I can
Mm.
still go to a hospital in Seattle. It's for malpractice coverage, actually.
Well, that's correct, but it is basically if you are licensed to provide, if you have insurance contracts.
Mm-hmm. So what's been interesting is some of these guidelines state to state have lifted or allowed for temporary licensure. As I mentioned, we're in Hyde Park, which is where the University of Chicago is.
Mm,
So one of the insurances that we take is the University of Chicago student insurance.
mm,
So a lot of the students went home when classes were canceled, and
mm.
home is
Correct.
all over the country.
Yeah.
So we really have to keep up with that and, make plans and
Well, it
figure.
makes no sense.
It doesn't make sense. And if they could, change
It's
with the
not
time,
practical.
great.
It's not.
Exactly.
It's not helpful.
Exactly.
It's
Exactly.
not conducive. It's not promoting well-being because you should be able to have access to different providers wherever they are,
Right.
depending on whoever they are. I mean, I
Right.
understand of having your locales and stuff like that, but I think people have moved on from that a while back. So
It's therapy's a very traditional profession, right? Like it's
it
hard to
used to
make
be.
these moves with
It
uh,
used to be. It used to be before we had all the executive coaches and
right.
the consultants and everybody else. Yeah, it used to be a long
Yeah.
time when I was going to the old graduate school. It used to be a profession you could only enter in certain ways.
Right. Right.
And there were a lot of guards on the doors. Now
Right.
somebody blew the walls down and everybody's rushing in to put up a canopy.
Right.
Yeah.
And this old school kind of method is being shaken up. I have a fax
Yeah.
machine in my home office and in my offices, and I like fax. who uses fax
Nobody uses
machines
it.
anymore? But we do. We still use fax
Yeah.
machines, and that's how I get some of our referrals.
Yeah.
Um, but there's lots of things that have sort of shaken up this profession, right? So
Yeah.
social media, right? I see therapists on social media, and they're putting great content out, and it's
Yeah.
really interesting, right? So again, this idea of making therapy accessible really excites me, right? I'm a therapist on a podcast. Who thought that would happen?
Yeah, no, for sure. I mean, it's so we need to help people understand, those who are not in the know about therapy or how therapy
Mhm.
works, or what are the different ways that therapy is delivered in the world. Those things have changed for sure. Things have transformed in many different ways with many different people.
And
Go
yeah,
on.
and maybe hopefully this will take some of the stigma away from mental health, which, as much as we fight against that, still exists. Um,
Yeah, 100%. There's
yeah.
the stigma with mental health, I think, will ultimately be overcome by a virtual type of reaction to certain illnesses, and people who are suffering from mental illness.
Yeah.
I think the more access people have, um, the more they'll reach out to other providers.
Hmm. Exactly. And if we could think about, mental health and physical health in one of the same, right? Like treating the whole person, right? This idea of comprehensive treatment is so important. And I see this so much in my work because, again, as we talked about, there's a very physical and hormonal aspect of maternal mental health and recovery. So uh, this these are uncertain times. These are times that are asking us to make great changes, and I'm glad to be a part of it.
Well, it's been a pleasure having you today, Jamie.
It's really
Really,
wonderful. Thank you so much for your time.
it is really appreciated for us at the Institute for Complex Individuation podcast to be talking to you and learning more about your practice and the amazing work you do.
Thank you.
Thank you
Thank you so
so much. Would
much.
you like to tell people how they could reach you? You want?
Absolutely. So Nurture Therapy, so www.nurture-therapy.com. You can reach us in our general mailbox, hello@nurture-therapy.com. We're online. We have an Instagram handle at nurture_therapy. And our phone number and all of our contact information is on the website, including a little bit about each of the wonderful providers that are in the practice. I mean, they are so fantastic and so skilled. I can't say enough wonderful things about them. And we're here. We exist, and other places out there exist too. And I'm really big on, if you call and for whatever reason we're not the right fit for you, I help people find the right provider. That's what feels important.
Thank you very much, Jamie. That's
Thank you so much. All right.
it's great to talk to you, and I hope to hear a lot more from you in the future, and hope we could talk again.
That sounds great. All right. Take care.
Have a
Bye-bye.
good one. Take care. Bye bye. This was the IFC's Individuation podcast. I am Dr. Lahab Al Samurai, and I will be back in times of corona and conflict.